Hello, colleagues. Welcome to the first online session of the MIX conference in Bristol. I hope you can hear me. If anybody hears me, can you say something? Let's see whether...
Yeah, it's loud and clear.
Okay, wonderful. So most of the colleagues, you are unmuted for now because only the presenters and the chairs are going to have the access to the microphones for now. But when we have the Q&A sessions, we can also lower the microphones, and then you can connect easily and then also ask your questions. But I suggest you to use the Q&A button on the top. So if you have any questions, you don't need to wait. You can just type it there. And then I'm with my colleague Pierre here, so that he's going to check all the questions. And then we're going to have a session for the Q&A at the end of all the presentations. So we are going to have the session on the immunization, and we have three distinguished colleagues who have their papers, and they're going to present in behalf of their colleagues as well. My name is Yadigar Coskun. I am with the MIX team, New York headquarters. I'm mainly working on the data processing. Of course, we are involving all these topics in one way or the other. So it's going to be my pleasure to invite our colleagues one by one, and then I'm going to just tell their names so that if they can introduce themselves at the beginning of their presentations, that would be amazing. Every presenter has 20 minutes to present their work, and then after that we are going to at the end of the session, we have like 30 minutes of Q&A, so that hopefully we are going to be on time. And as I said, if you have any questions, you can type it on the Q&A part, and then we are going to check them, and then we are going to publish them so that everybody can see it as well. So these are the things that I want to say. And then the first presenter is going to be Connie Lam, and I can give the floor to her. If Connie, you're ready, you can share your screen and you can start the presentation. Of course, first introducing yourself as well. Thank you.
Okay, so can you see my screen?
Yes, we can see your screen.
Okay, fantastic. Hi, everybody. My name is Connie. I am a researcher from the University of Sydney. I am a infectious diseases microbiologist by training. Recently finished my Masters in Public Health, and the work that I'm about to present was part of that Masters in Public Health. So, hello, welcome. I'm quite honoured to be the first in this session on immunisation. Thank you all for coming to listen to my talk today, which will be on wealth-related inequalities in childhood vaccinations in Fiji. So obviously this is part of the MIX conference. This data, the data for this study was from the very first MIX actually performed in Fiji in March 2021, just before the COVID-19 pandemic entered the country. It's a fairly comprehensive survey of the population, the very first comprehensive survey of the population, and the survey results were actually able to give us a really rich data set to better understand the factors affecting childhood vaccination rates in Fiji. So, needless to say, childhood immunisation has been recognised globally as one of the best ways of preventing infection and transmission of infectious diseases like pertussis, measles, diphtheria, and many others. So there have been targeted vaccination programs in Fiji, which have shown progress in reducing the prevalence of specific diseases like pneumococcal disease and hepatitis B. But the overall distribution of vaccine uptake and vaccination coverage hasn't yet been described in Fijian children, and there have been limited studies investigating the factors which may contribute to full vaccination coverage. And if I show you a map of where Fiji is, you might be able to see why. So on the left, you can see Australia, that's where I'm based, and to the right of that, near the international date line, is Fiji. And it's home to about 930,000 people who are spread out across an archipelago of around 300 islands. So it's not just one big island, it's actually quite spread out. The majority of the population live on the two main islands, the two big islands there, and the rest of the population are spread out across the smaller islands, which you can imagine are quite difficult to access and provide healthcare to. So this led us to design our study, which aimed to understand whether there were wealth-related inequalities in childhood vaccinations and the extent that socioeconomic inequalities as measured by a wealth index and geographical region can impact vaccination coverage in children in Fiji. So a couple of things to note in this study. The definition of full vaccination, as defined by the Fijian Ministry of Health and Medical Services, is here, and it includes 1 dose of BCG, 3 doses each of a diphtheria, tetanus, pertussis vaccine, and also a polio vaccine, and then 1 measles-containing vaccine, all to be received by the age of 2 years old. And the other thing that we decided on was to only include children aged between 12 and 23 months. And this is because children younger than 12 months would not have been old enough to be considered fully vaccinated because they're not eligible for some of the live attenuated vaccines. We extracted our data from the 2021 mix, specifically the children under 5 and the household modules. The mixed data will indicate whether there's a specific vaccine was received or not, and the date of receipt if it was available, but it doesn't record vaccination status. And what I mean by vaccination status is whether they've received everything that they're supposed to have received on time. So one of the biggest undertakings of this study was to determine the vaccination status of each child based on the definition provided earlier. And we had 3 categories for this. So whether they were fully vaccinated, partially vaccinated, or not vaccinated at all. And thankfully, there weren't many children in that age group that weren't vaccinated at all. For the second part of the study, we looked at other potential independent factors contributing to vaccination status, and the variables that we looked at included sex, area of residence, number of children in the family, wealth, maternal education, and access to internet and mass media, which were extracted from the household module. And we selected these based on previous studies which showed that some or all of these variables are independently associated with full vaccination in other countries, so low and middle income countries, but again, not yet explored in a Fijian context. I've put up a brief summary of the mixed data here. There were 417 children that met our criteria, so 12 to 23 months. And there's a fairly even distribution of the male and female children surveyed, and these were also spread out evenly between rural and urban areas. So not just in the main 2 islands, but also out on the smaller islands. About 52% of the children lived in households with only 1 child, and a similar percentage of mothers had had a high school education. So all households surveyed had some form of access to mass media, so television, internet, or radio. But at the bottom here was the main focus of the study, and that was to look at household wealth. And based on the summary at the bottom, you can see there's more than double the number of children living in the poorest households. So that's 28% of the children living in the poorest households, compared to 13% living in the richest households. We calculated the vaccination status of each child, and we found that the full vaccination rate for 12 to 23 months old was 85.6%. And that was interesting for us because it was much lower than the 93% overall childhood vaccination rate in Fiji, which includes all children up to the age of 4 years old. And we thought this discrepancy might be due to the fact that the first dose of the measles-containing vaccine is excluded from the calculation of the full vaccination. And that's to account for delays which may incur in children who've only just become eligible for the first dose of the measles-containing vaccine. So essentially children who have just had their 1-year-old birthday at the time of the survey and may not have had a chance to be vaccinated yet. So the graph here shows the distribution of the vaccination status of children across the 5 different wealth quintiles, the poorest to the richest, with full vaccination rates tending to be higher in wealthier households. And that's something I'll touch on a little bit later. We took 2 different approaches in this study. The first was to use a concentration index and concentration curve to measure the distribution and the degree of inequality between full and partial vaccination based on wealth scores. And then the second was to use a multivariable logistic regression to find any associations between vaccination and other independent factors. I'll briefly go through the principle of the concentration index and curve for those who aren't familiar with it. So the index and the curve measure socioeconomic inequality in a health outcome. And in this case, our health outcome was vaccination status. When there is no socioeconomic inequality, the curve is actually a straight line at a 45-degree angle, which you can see here. And it's also known as the line of equality. If the curve lies below the line of equality, it means that there is a concentration of the health outcome in wealthier populations, and the index will be positive. If the line is above the line of equality, it means that the health outcome is concentrated in the poorer population, and the index will be negative. The index itself lies between -1 and 1, and any values closer to 0 mean that they're closer to equality, so there's not much inequality at play. We produce two concentration curves and indexes, one for full vaccination and another for partial vaccination. And you can see from the figures here that the curve for full vaccination lies slightly above the line of equality. Oh, sorry, the curve for full vaccination lies slightly below the line of equality, and with the corresponding positive index. And the line for partial vaccination lies above the line of equality with the corresponding negative index. And what you can also see is that the degree of inequality is actually quite small. So the indices are 0.07 and 0.05, negative 0.05 respectively. And together, both of these curves and indices indicate that there's what's called a pro-rich inequality for both full and partial vaccination, which is to say that fully vaccinated children tend to be from wealthier households, and partially vaccinated children tend to be from poorer households. We weren't able to get significance values from the methods we were using, so this R package down the bottom here, which is something that we will investigate further, but it does give us an indication of what the trends are so far. The second part of this study looked at the association between independent variables with full vaccination. So the 7 factors mentioned earlier are again listed here, and at a p-value of 0.1, only household wealth and the number of children within the family were associated with full vaccination. And if we interpret these results separately, we found that children from the wealthiest households had 5.2 times the odds of being fully vaccinated compared to children from poorer households. And children from families with 3 or more children, so fairly large households, were 60% less likely to be fully vaccinated compared with children from single-child households. Both of these variables were then included in a multivariable regression model to calculate an adjusted odds ratio, but only household wealth remained weakly associated with full vaccination once everything else was adjusted for. And the adjusted odds ratio was slightly higher than before, where children from the richest household had 5.3 times the odds of being fully vaccinated compared with children from the poorest households. So our study results told us that 85% of Fijian children aged 12 to 23 months were considered fully vaccinated. But of these children, there were wealth-related inequalities in the distribution of the fully vaccinated children. Specifically, there's a pro-rich inequality where the children in wealthier households are more likely to be fully vaccinated compared with poorer households who were more likely to only be partially vaccinated. So after adjusting for the number of children within a family, children from wealthier households have approximately 5 times the odds of being fully vaccinated compared with poorer children. And aside from wealth, we found that there were no other independent variables that seem to be associated with full vaccination rates. So these findings are actually not unusual. Similar wealth-related inequalities have been observed in other low and middle-income countries, where households with more financial resources are better able to access and utilize vaccination services. So even though childhood vaccinations are free, poorer households may incur indirect costs associated with obtaining vaccinations, such as lost income. So if a parent has to take time off to take their child to a vaccination clinic, and if they need to travel a fair distance away to go to the vaccination clinic, this might cost the family and become a deterrent, essentially, and prevent the child from being vaccinated. Also, even though there is the association between the number of children in the household and being fully vaccinated was not significant, it's been suggested previously that the increased demands on larger families or larger households, for example, there's increased taking and financial and time demands. These households with more children these demands rather, may mean that there are delays in a child getting or receiving a vaccination dose, and sometimes it might even prevent the child from getting a vaccination dose. Of course, there are some caveats to take into consideration for this study. The first being that the sample size that we had was quite small. There were only 417 children included in this study, even though they were representative geographically in all other ways. Those 417 children only represent less than 1% of all children under 4 years in Fiji, based on the 2017 census. And notably, infants younger than 12 months were excluded, and children younger than 12 months are generally the most vulnerable in terms of being protected by vaccination. So including younger infants in further investigations may show additional factors contributing to full vaccination. And the other thing that we didn't consider was vaccination timeliness, and that wasn't calculated. Vaccination timeliness is important because it not only provides optimal protection to an individual child from disease, but it also helps to build herd immunity in the community. To calculate vaccination timeliness from the mixed data would mean further stratifying the age groups defined by the vaccination schedule here on the right, and then determining whether each child had received an age-appropriate dose within a designated time frame of whatever indicated age the vaccination was supposed to be at. So that's something that we are looking into, as is further investigating the concentration index by including a decomposition analysis, which provides a further breakdown of which components of wealth contribute to full and partial vaccination. It's hoped that the results that we've shown here and any other further analyses will provide policymakers some guidance in providing more equitable and timely access to vaccinations. So that's it for my talk. Thank you again for your time today and for the organisers of this conference for allowing me to present this work. Feel free to reach out if you have any questions or if you wish to discuss any further work. My email is below, and I look forward to hearing from you. And I might have to drop off a little early, but I'll try to come back on for any online questions later.
Okay, thank you, Connie. Thank you very, very much for the great presentation. And then we will see you most probably at the end of the session, and we will get the questions. That will be great. Thank you very much. And also thank you very much for keeping the time so that we can have lots of time for the Q&A. And let's continue with the second presentation. Oh, yeah, so let's continue with the second presentation, and Bridget is going to do the presentation, hopefully, but if she cannot, I will use the presentation. Let me find Bridget on the screen so that I can ask here. Bridget, can you unmute yourself?
Hello.
Oh, yes, you can. Do you want me to share my screen so that you can do the presentation?
Yes, please do.
Okay, so I will do that. 1 second. Let me present this. And let me try to do this and then share my screen. And then, yes, I think you can see it, right? Yes. So the floor is yours, Bridget.
Thank you very much. I'm Bridget Naphiyo from the University of Malawi School of Law, Economics and Government in the Department of Economics. I was a student in the Masters of Arts of Economics. I recently graduated, actually last week. My focus was in health economics, and this was part of my requirement to fulfill the program. So I'll take you through this study, that is the socioeconomic inequalities in immunization of 12 to 3 months old children in Malawi, a decomposition analysis. Please go to the background. Slide 3. Thank you. So as the first presenter stated, immunization programs are one of the most cost-effective interventions, preventing millions of illnesses and deaths worldwide. And a lot of governments have invested in this program to try to increase the coverage. And at a global level, you can see that immunization coverage has increased from 40% in the 1980s to over 80% in 2019. Despite this improvement in the coverage, from the State of the World's Children report produced by UNICEF, it was stated that there were a lot of unvaccinated children, especially from those that are in poorest households, from unempowered women and underserved communities. Please go to slide 4. That's at a global level. And when you come to the statistics in Malawi through the mix surveys, especially the 2019-2020 survey, you see that immunization coverage was at 72%. Despite it being at 72%, there were disparities based on socioeconomic characteristics. So you find that some groups of children, either in the poorest, you find that they're below the 72%, and some in the richest groups are above the 72%. And such differences compelled the need to investigate the extent of socioeconomic inequalities. Apart from that, in 2022, in Malawi, we had a polio outbreak, and in 2023, we had a measles outbreak. So it did show that there was something wrong, even though the coverage was improving. Slide 5, please. So the main objective of our study was to examine socioeconomic inequalities in immunization among Malawi's 12 to 3-month-old children. So basically, we chose this age group because it is the one that is targeted for, I think, the basic 8 vaccines, and also it has age-appropriate vaccines that are almost 14, I believe. The specific objectives were to measure socioeconomic inequalities in basic immunization. As I said, the basic immunization has 8 doses for Malawi's national vaccination schedule. We also wanted to measure socioeconomic inequality in age-appropriate immunization. So in the age-appropriate immunization, we have a number of vaccines that were added along the years, I think past 2011 and forwards. From there, we decompose the socioeconomic inequality in basic immunization, and we also decompose the socioeconomic inequality in age-appropriate immunization. Next slide, please. So this study, we did a bit of a trend analysis because we used the mix for 2013-14 and the mix for 2019 and 20. We also tried to find some supply factors from the Malawi Service Provision Assessment, but unfortunately, this survey was done in 2013-2014, so we didn't have a reference point for 2019 and 2020. To measure the socioeconomic inequality, we used the Ages Corrected Constitution Index, and to decompose the index, we used the work staff decomposition. So that is basically the formula for the Ages Constitution Index. It's just a covariance of the health outcome and a weighting factor based on the socioeconomic rank of the individual. In slide 7, for the decomposition, we basically assume that our health factor is a linear equation, and we substitute that into the urges index to actually decompose it and find which factors have the most impact to the inequality or have the most marginal contribution to the inequality. So I'll first start with the descriptive statistics. apologies, the table is a bit bulky. From the observations in 2013, we had almost 3,485 children. That's 12 to 3 months old. And in 2019, we had 2,737 children. So as you can see, for the factor that is the media exposure, you find that a significant chunk of the caregivers have regular mass media exposure. In terms of which region they belong to, a bigger population belongs to the southern region of Malawi. In terms of education, most of the caregivers have attained primary education only. In terms of the place of residence, that is the rural, find that a majority of children are also based in the rural area, and so on and so forth. Slide 9. So in this chart, we're just trying to see the trends from 2013 to 2019, how under vaccination or actually having the full vaccination is the sorry for that. The difference between the poorest and the richest quintiles is actually very minimal. Like the differences are like around 3%. Even for age-appropriate immunization, it's about 4%. For 2019, the differences are getting wider. You find that it's about 13%, and I think for the other one is about 16%. So the gap is getting wider as the years go by. Slide 10, please. So for the urges index, I'll focus for the national level. That is in column 2 for both tables. As you can see, in 2013, the index was insignificant, statistically insignificant. And in 2019, it was statistically significant and it showed pro-rich inequalities, meaning that coverage is better for 12 to 3 months old children that belong to wealthier households. For age-appropriate immunization, in 2013, it was significant with 0.034, but that was at 10% level of significance. And in 2019, it is even higher, and it is significant at 1%. So as you can see, it also confirms that the immunization coverage, inequalities in the coverage is widening. Slide 11, please. Following that, we did a decomposition, especially for the 2019, because they were the ones that were statistically significant at 1%. So as you can see that the contributions are mainly coming from education, the socioeconomic status. We also have a very big contribution from the place of residence. So for place of residence, the contribution is negative. For the other factors, it's more of a balance and an offset, because for secondary school, it is actually widening the inequality. It's a positive contribution, but for primary education, it's a negative contribution. So it was all depending on which socioeconomic factor the children belongs to. And slide 12 is just a visual representation of which factors are actually contributing the most. Next slide, please. So as you can see from this spider chart, there are some factors that are sorry, the spider chart is from -66 to 94. So you see that some factors are going inside, like in the negative direction, such as the rural, and then there are some factors that are also highly giving a positive contribution, such as the secondary education, the richest quintile, the middle quintile, and so on and so forth. So those were the factors that are showing that they are contributing the most to socioeconomic inequality. Slide 13. So as I said earlier on, the inequalities are widening from 2013 to 2019. The main factors that are significant to contributing to this per-rich inequalities are wealth, maternal education in place of residence. And this is actually very consistent with a lot of studies by Bobo and Hyan, Asman, and Ngodi 2015. In conclusion, the findings also support the UNICEF 2023 report on the state of world's children, which sounded an alarm that trusted methods have failed to immunize the most vulnerable. So our policy recommendation was to call for interventions that improve affordability and accessibility of vaccines because wealth is a factor. And since education is also a factor, we're also calling for interventions that educate caregivers of the benefits of child immunization to ensure equity. Thank you very much for having me in this session.
Thank you very much, Bridget, for the presentation and also keeping the time very good. Let me stop sharing. And then we started to get the questions one by one. And just a reminder, you can use this Q&A button on the top for your questions. That would be great. We can go back to these questions after the last presentation. And now I'm going to give the floor to, one second.
Kanchan.
Yeah. Yeah, Kanchan. Kanchan, you can share your screen. I think we tried it. And the floor is yours.
Okay. Thank you. Okay. So share screen. Yeah. Am I audible?
Yes.
Okay. Can you see my screen?
Yes, you can see your screen as well. Yes.
Okay. Okay. Well, good afternoon, good morning, good evening, depending upon your time zone. I am Kanchan Thapa, presenting about equity among never vaccinated under 5 children in South Asia from the 6th round of mixed survey in South Asia. So today, Kanchan, myself, and Rita Adhikari, my colleague, will be presenting about the never vaccinated children status equity in South Asia. So for today, that we will talking about the little bit of background and why we conducted this study and method applied for this study and results, recommendation, conclusion, and reference. So at the same time, I am showing this photo. This represents Nepal, and it is the one of the remote province and remote part of Nepal. Probably the highest altitude of Nepal, where health workers have been vaccinating the child with OPV. So let's talk about a little bit about the immunization. So as we discussed earlier, immunization is one of the most powerful public health interventions worldwide. So it is one of the most cost-effective interventions to promote good health and well-being. In 2023 only, there were 14.5 million children missed out any vaccination. So we call the zero dose vaccinations. So these zero dose means the children who do not receive any vaccinations till the date or at the time of the study. So here we know that from our previous presentations and also from the literature that access to the vaccine, geographic and socioeconomic status are the major challenges and major factors that contribute the complete vaccinations. Similarly, in this aspect, that equity is the organizing principle of the Gavi for the year 2021 to 25. As documented in Gavi 5.0 strategy. So Gavi is one of the major donor for the immunization program worldwide for government and for the UN agency. So in this document also, zero dose is considered as one of the organizing principle where equity is one of the organizing principle. Similarly, we do have Sustainable Development Goal and Immunization Agenda 2030. These also talks about and advocates for the complete immunization and also talk about the zero-dose children. So for this study, we extracted the data from 6th round of the mixed survey in South Asia. Study period was April to July 2024, and the countries included were Nepal, Afghanistan, and Pakistan. So analyze informations are place of residence, age, sex, mother education, disability of child, and similarly disability of the caretaker, insurance coverage, similarly breastfeeding history, vaccination card, birth registration status, wealth index, and and the number of never vaccinated native children under 5. So we use SPSS, MS Word, MS Excel, and R for the data analysis purpose. Okay, so we also compared the never vaccinated child status by the country. We compared Nepal, Afghanistan, and Pakistan information. So these are the number of the children whose information has been compared here. So if you talk about the Nepal, the number of never vaccinated children is 41.9%. Afghanistan, it comes to be 61.4%. For Pakistan, we disaggregated data for the province. So for Punjab, it's 24.2%, Sindh 39.4%, Khyber is 60.4%, and Balochistan is 73.6%. So these are the number or percentage of the children who received none of the dose of vaccine. While we talk about the status by wealth index, we try to compare it. So in Nepal, we compare it. So if you compare the data, it comes to be 1.10% for richest quintile, and it comes to be 28.90% for poorest quintile, and there is similar kind of trend throughout the countries. And for Afghanistan, you can see the data. It's 25.20% for richest and 7.4% for poorest. And similarly for Punjab, Sindh, Khyber, and Balochistan, the trend continued, which clearly indicates that there is a huge equity gap among never vaccinated children. So we also tried to compare the data by the place of residence. So here in Nepal, if you compare the data of urban and rural place of residence, in urban there is higher percentage of zero dose children. In village, it comes to be lower. And if you compare the data for other areas like Afghanistan, Pakistan, there is clear disparities between rural and urban areas. The number of children who never have been vaccinated is higher in rural area in these two countries and throughout the province of Pakistan. And we also tried to examine the data by the sex. So in Nepal, there is not a big difference. And in case of Afghanistan, it is not a big difference. However, it comes to around 2%. However, if you go to the data set of the Pakistan's inside the province, it comes to it comes to have higher difference for Punjab, and it comes to and the similar trend continued throughout the provinces. Yeah, we also try to compare the data by age. In Nepal, the data it comes to be 24.20% for 0 to 11.29 11 months, 29 days children. So for completed 1 year, it comes to be it represents the data from 12 to 23 months. It's 28.50%. And for the children who already completed 2 years and less than 5 years, the data comes to be 47.30%. And similarly for Afghanistan, uh, uh, for less than 1 year, it's 32.20%, and for more than 2 years, it comes to be 38.90%. And if you compare the data for Pakistan, and throughout the province, the similar kind of trend can be seen. However, there is the provincial differences between uh, Punjab, Sindh, and Khyber, and Balochistan. In Balochistan, that less than 1 year children, there is higher zero dose, and completed 1 year, there is uh, quite lesser zero dose if you compare the data. Similarly, we try to compare the neighbor vaccination status by the mother education group. We compared it into four groups: not educated at all, basic education, and secondary education, and higher education. In Nepal, there is a very little children among the highly educated age group whose children were never vaccinated. So we can clearly see from the data that the highest number of the children who were never vaccinated were the children of the mothers who were not educated. So we can compare the data for the countries and for the province of Pakistan. Similarly, we try to examine our data by the status of functional disability. In Nepal, among the non-vaccinated children, 2% of the children had functional disability. And for the Pakistan, for the provinces, we try to examine the disability status among the never vaccinated children, and the data comes to be 14.9% for the Pakistan and for the Balochistan, and the least for 7% for Punjab. So we have these kind of data for Pakistan. Similarly, we try to explore the status by the caretaker disability. In Nepal, there are very few caretaker who were disabled and their children were zero dose. And Afghanistan, it comes to almost like zero. Maybe there is no data for Afghanistan. If you compare the data for Pakistan, it comes to be a 2.50% for Punjab, 1.90 for Sindh, and 1.50% for Khyber, and 2.10% for Balochistan. So we can see the status of disability of the caretaker among the non-vaccinated children. Similarly, we try to explore the status of never vaccination by the health insurance status. In Nepal, the children uh, were found to be never vaccinated, though there is health insurance program. So the data comes to be 3.20% in Nepal, and Afghanistan the data comes to be zero. And we can see the status by province in Pakistan. For Punjab, it comes to be 1.30%, Sindh 0.40%, Khyber 1%, and Balochistan it's 2.40%. Similarly, we try to examine the status by the birth certificate. So it comes to be the multi-sectoral approach as we talk about the birth certificate. So if you compare the data for the birth certificate status and their never vaccinated status, so those children who do not have birth certificates, they were more never vaccinated in Afghanistan and Pakistan. In context of Nepal, those children who have a birth certificate, though they were more likely to be never vaccinated, the data comes to be 60.4% for not having the birth certificate and 39.60% for having the birth certificate. And if you compare the data for Afghanistan and Pakistan, there is quite a big difference between never vaccinated children status by birth certificate. So based on the data, we can say that we need to have country-specific intervention. The intervention should focus to hard-to-reach area, hard-to-reach people, poor, child with disability, and children from uneducated mothers, female child, and disabled child. So we need to have specific interventions to address these uh, non-never vaccinated children status. Also, early enrollment in birth certificate program is recommended. It can bring children in the mainstream of the service utilizations, which ultimately contribute towards the complete immunization, which help to reduce the zero dose. Similarly, multisectoral approach is required to fill the gap, equity gap in the vaccination program. Similarly, for the research based on the qualitative information, similarly primary data, which is specifically targeted towards the zero dose children, and also based on the large sample size is also recommended. At the end, we would like to conclude that we examine the huge equity gap among the never vaccinated children, which requires immediate attention in South Asia. So we observe differences based on gender, place of residence, wealth index, mother education, health insurance status, and child registration. Similarly, disability is another aspect to consider in ensuring that all the children receive the vaccinations. So our journey towards the complete immunization is only possible if we address the zero dose based on our targeted interventions to reduce the number of zero dose children. So we have taken these references for making our presentation. So thank you so much for your kind attention. If you have any questions and if you want to collaborate further, I am always ready, and I welcome you. Thank you so much for your kind attention. Thank you so much.
Thank you, Kanchan. Thank you very much. Colleagues, we have some questions on the chat. I think we can start with them, and then if you have further questions, or when you come up with the questions when we are answering these ones, or the colleagues are going to answer these ones, then you can always have the chance to write them on Q&A, and then we can always give you the floor if you want to ask questions in person as well. So I'm leaving the floor to Pierre so that he can start the questions or moderate the Q&A.
Thank you, Yadigar. The first should not be in the chat, in the Q&A as it was said. So the first one that came up is how the wealthy and poor were grouped. Was it from a World Bank report? It was immediately after Connie's presentation, so I think Connie may feel, if you are willing, you can answer the question. But it's actually relevant to all the presentation because we saw data that are some comparison with wealth categories. So Connie, would you like to answer the question, or otherwise Bridget or Kanchan, you are welcome to go ahead.
Yeah, so should I go?
Yes, you can go ahead.
Okay, thank you so much. So wealth index is computed in our mixed data based on it is already in our data set. I think it is done through the principal component analysis method, and it is already in our data set. So we just included the information for our analysis. Yeah, thank you so much.
Thank you, Kanchan, for the answer. Just maybe, yes, you're absolutely right. It's done through principal component analysis that is based on asset-based, isn't it? It's mostly in the household questionnaires where we collect information, or the mixed service collect information on assets. Do you have a fridge? Do you have this or that? And through the principal components analysis, the categories are the households are categorized between wealthiest and poorest in 5 equally populated categories from the poorest to the wealthiest. Yeah, I think that
Yeah.
the answer is
Yes.
already answered.
Similarly,
The question is
there
already
is
answered. So we can go to the next one, which is specifically for Kanchan. So regarding the never vaccination status by health insurance, is it referring to not enrolled in health insurance program having a higher never vaccinated percentage? That's the question. Kanchan, please, if you could
Yeah.
answer.
Okay. Thank you so much for question. In our analysis, that we included the children whose the number of children who were never vaccinated, and we examined the data in terms of their enrollment, their family enrollment in National Health Insurance Program. So based on the data set that we found the result. So it means that the children who were never vaccinated and the children and their family who have been enrolled in health insurance, we compared the data. And so in Nepal, it can be the relatively new concept. However, there is no universal coverage of health insurance program. So, however, we try to compare the status by their enrollment in health insurance program. Furthermore, the health insurance program is mostly focused on like curative aspects for the disease, like a disease treatment, and for the program like vaccination. As per my limited knowledge, I think they have that limited focus or limited emphasis for the vaccination program in health insurance program. So, however, it is one of the indicator which ultimately lead us towards the universal health coverage. So I included the information for my analysis. Yeah.
Thank you very much. Now, we don't have other questions in the Q&A. Of course, all the presenters said that everyone is free to contact them to have continue conversation on the subjects they presented. I wanted myself to make a comment on the excellent presentation made by Connie, but she made a comment. You made a comment, Connie, that the sample size is a bit small, 417, and it represent only 1% of the population of the children of that age group, 12 to 23 months. I would like to give a more positive maybe view on the size of the sample, because 417 actually it is a good sample size in this approach, this kind of survey. The issue is not so much about what percentage of the population is represented in the sample, but more about the methodology to get that a sample that is fully representative, which of course in mix is always something that is done very carefully, so that through the clustering process and the stratification, we try to get a very good representation, of course, of the population. So even although it might be only 1% of the population of children who are in the sample, if they are really representative of the full population, the results are going to be really quite reliable. And yes, so I have not seen the data, but if the response rate is high, if we have not lost information on the children that were sampled, if the coverage was good, response rate was good, then the results at this sample size would be excellent, actually, in terms of reliability. It depends, of course, how much disaggregation is going to be done. If at this number we disaggregate between the 5 category of food, it still remains a good sample set for each category. But if we were to disaggregate into between 20, 30 provinces, then you might start to get a sample that is a bit too small. But so I wanted just to comment positively that this is really a very satisfactory sample size.
Yeah, thank you for that.
I don't see any other questions.
Yeah, thank you for
some
clarifying.
colleagues would. Connie, you want to come in?
Oh no,
With
I was
your
just going to say
beautiful
thank you for
daughter?
clarifying that. Yes, I later on I did realize the mix do try to create a representative sample set, especially geographical distribution, because of the way Fiji is located regionally. I know it's very difficult to try to get some of the families to answer the surveys, but we can certainly further look into sort of disaggregating the data to see how we can sort of best fit that into our further analyses. But yes, thank you for your comment.
And I want to continue, not to steal the sessions, but when I was listening your presentation, Connie, I mean, you were saying that there's a difference between the partially vaccinated and fully vaccinated among the poor households. So the poor households are getting more partially vaccinated children than the highest group in the wealth index, the wealthiest. So when I was thinking that when I always look at the wealth index and the immunization correlation or any other thing related with the health, I always think that there are some campaigns for the poorest areas, so to increase the immunization. So that might be resulting in this partially immunized children than the full ones, because when they have the access, or if there's a campaign, so they have the first dose or the second one, so that they don't have, not the second one, the first dose, so that they cannot maybe go and have the full one. So that might be a kind of in relation to that one. With the other things as well, with the wealth index, and that might be also think about these, the campaigns or the programs for the poorest areas in the countries that might change the results as well. So, but it's a further analysis, or you need to reach to other records so that you can support this idea. But this is always keeping it in my mind. And also with the wealth index in especially the islands or the small populations, it's difficult to differentiate the households from each other. So if the island, let's say, everybody has the access to most of the things, or most of the people have the similar household items, so it's difficult to differentiate the households. That might result in the fluctuation of the results. Like when we look at the middle categories, we might have higher, and then it goes again like this. There's a kind of fluctuation in the results. So that might result in every country or every population who are using the wealth index. And if we cannot differentiate them clearly, so that might result in this one. But I like this concentration index for both of the studies that is presented today. So it gives you an idea how you can see the results. So that's very interesting for me. And sharing the significance on the web graph also was very helpful on the second presentation that we had. I can comment on this one. And for the third one, that we had the presentation, then we have the Pakistan surveys. I was looking at the names, and I realized that they are not reflecting the survey names that is presented officially in the Mix website. So that might be good to check their official names and update the presentation and also the study, so that nobody will complain, because we know that sometimes the countries are very sensitive about their the names and the regions. So that might be one comment that might have for the third presentation. Yeah, that's it. And one other thing before we close the session, I think we are going to close the session because there is no additional questions, is the comparison of the wealth index among the countries. So even among the same country, when we calculate the wealth index from one round to the second round, so the things might be a little different because the country is changing, the ownership of the things are changing. Some regions might be, let's say, the most of the households coming from one region might change to the other one as well. So when we are comparing the wealth index, we might be a little bit careful of sharing the results, thinking that we have the hands up, we can always give the floor to the colleagues. So let's say that if you're comparing the wealth categories in, let's say, the Oman, which is a wealthy country, with the wealth index categories in Afghanistan, so the comparison of the results might be a little bit difficult. So every country has their own wealth quintiles and their, of course, relationship among these quintiles. So this is one thing that I want to remind all the colleagues that are using the data. Other than that, we can give floor to first Said, and then we can give Anwarul as well. So I am trying to unmute. Yes, Said. I think maybe you can try to unmute yourself as well. Said, can you try to unmute yourself and speak? I think I give the, yeah.
Only go to one.
Yeah, let's try Anwarul. Yeah, Anwarul, can you try to speak? Yes. Now maybe you can speak. Maybe not.
Otherwise, you can put in the Q&A.
Yeah, if you can type in the Q&A, that would be great. If it's a comment, even that would be great. Both Said and Anwarul, can you write your comments and the questions in the Q&A? Sorry, I couldn't manage to give you the floor. Oh, what?
He is Anwarul since he was able to unmute himself.
No, I think I did for both Anwarul and Said. I did unmute you, so that maybe you can try to speak, but let me try to change your, 1 second. I'm going with another option.
Otherwise, the Q&A would be a good place if it's possible.
Yeah. While I'm trying this, if you can try to type it. Oh, let me try this. I made you a presenter, Said. Yeah, can you try to unmute yourself and then speak, Said?
And Anwarul has put a question in the Q&A.
Let's see.
We can go maybe to the Q&A and then while Said is trying.
Yeah.
So okay, I'm going to unmute myself. Okay.
Yeah.
Okay, the question from Anwarul is to please define what is 0 dose and never vaccinated. I don't know for who the question is.
It's for Kanchan.
It's for Kanchan.
Yeah.
Okay.
Yeah.
Kanchan,
Okay, thank you.
Comment?
Yes, sure. Those children who were never vaccinated means those children who never receive any dose of the vaccine is called never vaccinated children, which is also said as a 0 dose. Means they don't receive any kind of vaccination. Similarly, I think I found a question. This is I think I can answer it. Nobody talk about the complex survey design and analysis. I tried to analyze the data, multiplying it with the survey weight. However, in some of the data set, the weight is not properly, or it is not like we can compare in that way. So I didn't talk about I didn't talk about the sampling design and weighting to make it representative. Yeah. Thank you. if any question, I'm happy to answer. Yeah.
There is another question for you, Kanchan. Do you have how to reach data? So I believe, did you analyze in the vaccination status by how to reach for outreach population? Over to you, Kanchan.
So for hard to reach population, we only analyze that urban and rural areas. Also, there is a provincial data. So I cannot comment exactly at this moment, but we try to analyze the information based on the indicator that is presented. Yeah. So hard to reach means those children who is deprived of the facilities and not coming towards our men's service provision. I can say like that at the moment, but in terms of exact statistical definition of hard to reach, I need to rework, I think. Yeah.
Thank you, Kanchan. There's yet another question for you. The percentage of vaccinated, I guess, is very high. Can you please mention the sample size, both weighted and unweighted?
Okay, thank you so much for the question. Let me check my PowerPoint once. So the number of vaccinated children seems to be very high. I think it is linked to the methodology that if you read the report of mix and other surveys, that it consider the data for I think 12 to 23 months. For this study, we included the information of the children who are less than 5 years. So we try to explore everything that is available to us. For Nepal, that we try to explore the information of children. Total never vaccinated children, it comes to be 1,272. For Afghanistan, it comes to be 8,840, and for Pakistan, Punjab, it comes to be 60324, and for Sindh, it comes to 5,800, and Khyber, it comes to be 7683, and Balochistan, it comes to be 7,568. So in terms of the information, okay, please wait. So for Nepal, the number comes to be ever vaccinated numbers comes to be the 740, and it comes to be 532. So altogether, the data comes to be 1,272. Yeah. So. Yeah.
Thank you for the answer. There is a comment from a colleague that states that I believe that there is a difference between never vaccinated and zero dose. And zero dose, the term zero dose is sometimes used to, for example, for multiple, the vaccines that have multiple doses, to say that they have not received you can have received the dose 1, for example, of polio, but not have received the dose 0 at birth. So depending on vaccines, that's what is commented here. The expression zero dose or dose 0 can have different meaning. If you wish, Kanchan, to comment on that, you feel free to do so.
Okay, so I didn't see the comment here. Can you please read the comment once for me?
Okay, it is a well, it has been posted here. The comment is this: I believed that there is a difference of never vaccinated and zero dose. Zero dose is that children not received the DPT1 or Penta1, but it's the form of a question also. So basically, again, to never vaccinated and zero dose, the way you used it in your presentation, does it actually mean the same thing? or does it refer to some multi-dose vaccines and not having received any of the, for example, the first dose of that series, or some vaccines have a 0 dose that can be given just at birth, and if you skip that one, not 0 dose, dose 0, isn't it? And then if you skip that one, you will get to dose number 1 directly. I hope I didn't, I was clear. But you can go ahead, Kanchan, and comment on that.
Yeah, so for these presentations, I can remember the indicator. It's IM 11. It says that the number of children who were ever vaccinated and never vaccinated. That means for our context for these presentations, I use the information that the children who doesn't receive any dose, none of the dose of the vaccine. Yeah, that's all.
Okay, I believe it's quite clear. Of course, the terms are sometimes used a bit differently, but you have
exactly.
clarified how it was used in your presentation, so I think it's very good.
Yeah.
I don't see any other hand or other questions.
I don't see as well. So thank you very much.
Sorry, Yadigar, you're just muted. We can't hear you.
Sorry, you are muted.
Oh, so I am muted. Yes. Sorry. So let's give the floor to Omar. I'm trying to enable his microphone and then make him a presenter. So Omar, can you try to speak? No, this is not working. See? Yeah, it would be great to Omar to type in the Q&A. I think you might already did. No, you didn't. Sorry that this giving the floor to the the participants, it didn't work for me today. Yeah. We'll wait for a couple of seconds for you, and meanwhile I can repeat what I said. So we have the mixed email address on our website. So if you have any questions with the data, any type of analysis, or if you have problems with producing the same numbers that we have in the report, you can write an email to us, and then we are responding it as quick as we have the chance. Sometimes we are asking the colleagues that is working on these topics specifically, so we have the chance to go back always to the countries as well for the specific analysis. So it will be great to see more work on the mixed data. That is very that's making us very happy. So Omar, I think we are going to end the session. And then if you can write to the presenters or to us, we can find, of course, chance to reach them and then possibly make your questions answered. Thank you very much, everyone. Thank you very much, colleagues, for the presentations, and thank you very much for joining us online. So this was the first online session. We have another parallel session as well. We have many other sessions during the day. So hope to see you online, and then have a wonderful day, evening, and night, morning. Have a nice one. Bye-bye. Thank you, Pierre.
Welcome.
Thank you.